for that one.
Yeah, and you don't need to be perfect. Perfect is weird. And it really is about like you don't need to have all the solutions, even naming it in the moment, like, oh, I just upheld the tyranny of the majority, or ugh, this thing happened. Like that's really kind of first step because I think, and I see beautiful Veronica McKinney, so I'm waving and saying hello, and we'll let you guys wrap up and move on. But I think the greatest myth for me is that first pattern, like that erasure and invisibilization, and this assumed exhaustive jurisdiction of crown law and crown ways of doing things that just totally ignores the fact that we are still here. We still have our laws, we still have our ways of being, and we still have rights and jurisdiction. So that can't be ignored, but it is definitely part of the myth that endures. So yeah, so thank you so much again for having us. We're really grateful that we were able to share this time with you today.
Thank you so much, Doctors Ben Smith and John Blood, both for that answer and for such a thought-provoking presentation today. I think all of these lessons that you've discussed today are particularly important for us working in organ donation and transplantation as we try and build more reciprocal, respectful partnerships and relationships. So, on behalf of the CDTRP Patient Family and Donor Research Forum, a huge thank you to you for sharing your knowledge and your time today. We're so grateful for the work that you are doing and that you're continuing to do. So, thank you so much. Well, with that, Dr. Vanessa McKinney has joined us now. Or Dr. Veronica McKinney, my apologies. So I'm very pleased to introduce you all to her. Dr. McKinney is a Cree woman whose family originates from Northwest Saskatchewan. She was brought up in her traditional culture and is the director of Northern Medical Services, which is a division in the College of Medicine at the University of Saskatchewan, which provides medical care to northern, primarily Indigenous communities and municipalities. Dr. McKinney has a keen interest in research, innovation, and education, as well as a passion for improving health outcomes. Her knowledge and understanding of nehiyaw approaches, vast experience, and ability to collaborate and ever-present curiosity provide strong insight into challenges along with strengths and opportunities for improved health for all. So welcome, Dr. McKinney, and I will pass it off to you.
Thank you so much. And I'll just get my slides up here. Hopefully you guys can see that okay. So yeah, my talk is Gun, which is barriers basically. And I don't like to be negative, but there are definitely barriers and challenges when you live in remote northern communities or even just in northern communities in general. And while I'm talking primarily of northern Saskatchewan, because that's what I know, the reality is that these barriers exist in many northern places throughout Canada for sure. And I always like to start by acknowledging the land and that, in our traditional ways, the land is a relative of ours. Like, we talk about kinship, and when we talk about the land, you may have heard, we talk about Mother Earth and Father Sky and our brothers and sisters, the trees and the rivers and the lakes. So when we think of it in that way, the land is really a part of us and who we are, and especially in northern locations. Many of us Indigenous people still have strong ties to the land, and it is part of who we are. And in some ways, I always laugh too, as a family physician, that we talk about writing a prescription of going out to walk outside, just so that way your mental health will be improved. So that's just a small example of how we can be healed by land as well, for sure. So you probably heard way too much about me, but one of the things I always like to do as well is to honor my ancestors, including this is my Kokam and my Musham, and I have both Métis and First Nations in my background. So it's always, as is with many Indigenous populations, very complex for sure. But that I am a nehiyaw and I'm Mitchef, and I'm multiple titles throughout. I've had a long and torturous route, is the way I like to put it, but it's been fun. I'm currently the director of Northern Medical Services, so we provide all the medical care in Northern Saskatchewan, essentially. So just a few objectives. I always like to put them up just to hopefully give you something to maybe focus on a little bit. Northern Medical Services is a tripartite organization. So we are uh, a tripartite with Indigenous Services Canada and with the Ministry of Health in the province, and then all sort of through the College of Medicine at the University of Saskatchewan. But we work very closely with tribal councils and health authorities and cross both into First Nations communities as well as provincial sites and such. And this just gives you a map of the areas. The colored areas are the areas that we serve, and it's almost half the province. And about three-quarters of this geographical area is about three-quarters the size of the Yukon. So quite a large area. Population is around 45,000, and we serve over 35 different sites. And of course, there's lots of little places in between as well that we serve for sure. In this area, there's greater than 85% of our total population are Indigenous, and that includes First Nations and Métis. But this is actually higher than the Yukon or the territories or even Nunavut. And then greater than 65% of our population speak a language other than Cree, other than English as their first language. So Cree and Dene are common languages for sure. And many of the population do not have a grade 12 education at 29 years of age. One of the positive things we're seeing is that there has been a shift where people are coming back to get their education after maybe having families or maybe into their 30s, 40s, sometimes even into their 50s, but it's increasing, which is great. And half of the total population lives on First Nations territories in these areas for sure. In our case, as in other areas, over 50% of our population are under 25 years of age. And what this means, and we have very few elders, I would say, relatively speaking. So this means two things. One is that we actually have the upright population, upright pyramid, whereas the rest of the population is the inverted pyramid. That's important for things like policies and when we're making approaches to address general populations. It can mean that our populations, especially with Indigenous populations and in the North, are left out of these kinds of policies and such. Also, there's a high dependency ratio. And what that one means is that the people that are supporting the very young and the very old are supporting a lot more people. And so their risk of health and the detriment that that may bring to the people that they're serving or supporting has a much higher implication because more people are affected by that for sure. So we have a reduced life expectancy in general. It's usually about 5 years or more. What I see with my patient population as a family physician is that it's around 10 to even 15 or 20 years, depending on where I'm at and where I'm going. I do think it's increasing in terms of um, uh, the decrease in the difference between non-Indigenous for sure. And there's increased disparity and loss of life with those in poverty being at significant risk. And just to give you a ballpark idea, about half of all kids living in northern Saskatchewan live in poverty. So we're starting out with kids not even having really great chances to begin with for sure. The geography, includes like a lot of areas that are remote and include fly-in communities. And oftentimes these communities, it can take quite a long time to get there. So even if I were to get into an airplane here in Saskatoon and fly to some of our northern communities, I could be flying for 2 hours. And so when you think about if I were to actually be traveling west, I would probably be in Vancouver if I were to do that. So it just gives you an idea of the vastness and the distances. And there are also long distances to care. So in one of the communities, remote communities that we serve, we kind of work in a hub and spoke model. And so our physicians come from one site, but they have to go on a plane for about an hour to get to that community that they are serving. There's also seasonal roads, things like winter highways and things, where you are able to travel across when the ice is thick enough on different lakes or rivers and things, but not able to drive in the summer. And of course, this is having more implications in terms of environmental change and warming trends where we're not necessarily getting the thickness of the ice enough to drive on the ice. And we've seen people go through the ice at times and unfortunately suffer some negative, very bad consequences, including death, but that we're not even able to get the resources out there as well. And of course, harsh weather conditions where we're seeing variation, like very extreme variations, like colder temperatures, more thunderstorms and such, and lightning strikes for those different areas as well too. Um, and transportation is then affected as well. So we do have planes that go out to all of the different sites, but these are becoming more and more limited. There aren't always what we call scheduled flights. They're often chartered or trying to have regular flights that are chartered at regular intervals. But it does mean that there's less numbers or ability to get out in and out of the community or to bring things into the community like food and like medical supplies. There's increasing costs with both planes and land transport. Of course, gas is getting to be more of an issue for sure because of and increases the cost as well. There are weather disruptions. There are times in some of our communities that we can't get in by plane or even by vehicle because of the horrible weather conditions for sure. And patients often need escorts. When patients are sick, they need somebody to kind of help them along and to be able to help them to navigate and to make sure that their needs are being met and such as well too. And driving often requires long hours in the vehicle. So when people are going down, for instance, down south for medical appointments, they're often traveling in vans that they might be in for about 12 or 18 hours all told by the time they start and finish. And they have to go to everybody's appointments, and they don't always have access to great food when they're traveling down south and such as well too. So transportation just isn't just about distance. It's also about logistics. It's about cost. It's about coordination. And it requires a lot of these things to make things work. Even things like having coordination through non-insured health benefits, often they need 72 hours in order to be able to book these transportation and such. So when you think about how the trips down south, how many are required, especially in terms of transplantation and the testing and all the different things that need to happen, it begins to, and each one requiring an escort, leaving your home, leaving your family, you begin to understand some of these things as barriers for people to be able to access the care that they need, for sure. Um, this just is one with a picture from our beautiful north. So we aren't all prairies, that's for sure. Um, One of the problems too is access to care, and actually we have less access to things like specialists, especially when living in communities outside of the hubs that we kind of have where the physicians are located, and then kind of go out to the other areas. These hubs, by the way, may be a community of like say 1,800 people. So we do bring specialists in from down south for a day to come in and be able to see some of the patients, but often they don't include specialists who may be able to talk about organ transplant or would be able to even help with getting some of the initial diagnoses and things happening. Most of our specialists are things like ENT, psychiatry, pediatrics, those types of things. Many of the visiting providers, so because we work in a hub and spoke model, often these physicians are not necessarily living in the communities, even though it's a hub. They may be working more itinerantly, so coming in for a couple of weeks and out for a couple of weeks, and then traveling out to the outlying communities as well. The other thing that we're seeing more and more of is that a lot of the providers, especially at the nursing stations, are changing. So we may have nurses, and of course, there's different kinds of nurses, LPNs, RNs, AAPs, NPs. That's becoming more and more confusing for both patients and other care providers. Things like physician assistants, community-based paramedics. There's all kinds of different providers, and it's leading to less consistency and more change in terms of who the patients are seeing and understanding who can do what and how they can manage these things. And that really leads to a lot of the fragmented care that we're seeing and that patients are experiencing, adding to the frustration of the patient and the challenges of them trying to navigate this system when there's so many different people that they're talking to and trying to figure out what each one is saying. And increasingly, in many of our communities, we've had a lot more violence happening as well. So, less care providers that are willing to come out and challenges for patients to get to the healthcare centers. So, even if you're living in a smaller community, it's not always safe to walk to go to the healthcare center, or it might be quite a distance and you need a ride. Or there's things like like we have a lot of dog packs and a lot of dog bites. So things like that can be very challenging for sure. Food security is another big issue for sure. So, like a head of lettuce can cost several times more in the north, if you can even find it, compared to Saskatoon, and is likely not very uh, fresh, that's for sure. Oops, sorry about that. And a lot of sorry about that, visiting providers to the outlying communities change, oh gosh, there's a lot more higher costs in foods. Like, for instance, if you buy a 4 liter of milk in one of the communities, it's about $14. That same community, really, in order to get groceries, you might be able to find the milk at a local gas station, which is may or may not be open, but the actual grocery store is about 3 hours away. And not everybody has access to a way to get to these places. So that's been very challenging for many people for sure. And there's less traditional foods that are available both because of climate impact and development, resource development, all these different things. And the cost of even being able to obtain traditional foods, you have to have a rifle or a fishing rod, being able to get out to these different locations, being able to manage and do the work that's required for that. We also had a recent study that was done by one of our researchers within Northern Medical Services, identifying 27 cases of scurvy in one area in northern Saskatchewan. So the costs are much higher. The access is very difficult. And when you're talking about trying to be prepared for organ transplantation or even being identified as somebody who could manage, but you're not able to manage your diabetes, for instance, because of the food. These things have huge impacts as well. And as I was talking about, health is deeply connected and tied to the land, especially in the northern parts of the province and of the country for sure. And changes to the land really impact wellness. And what we are seeing is that there's increasing resource development, which is having impact on the land. It's changing the numbers of people that are coming in, the development that's happening. But you also see oftentimes close to these mines and such are bodies of water, lakes, which is our access to things like fish and things like that. So nowadays, we have to be careful with how much fish we're eating, and there are places that we can't eat the fish from. And there's also concern in certain areas around being able to collect the berries or to be able to eat the berries. And so there's all kinds of different impacts that we're seeing from these resource development and changes as well to the environment. We're seeing more different insects and things coming further north. We never saw ticks before, and now we're starting to see some of those, for instance. So a lot of changes that we're seeing for sure as a result of the environment, for sure. And then, of course, the development can also limit the access to traditional medicines and to food systems as well. There are also cultural barriers for sure. And so when we think about the language mismatch and we talk about medicalese, but the reality is a lot of times the language that we use to describe things in medicine are complex and they don't often necessarily translate directly in different languages. So it's always a little bit challenging to know that even if you have a translator, whether or not the message that you're trying to get across is actually getting there because the differences in how the languages are quite different. So often in the Cree language, for instance, we use a lot of descriptions, but it's not describing in the same way that you might be in English. And so it can lead to a lot of misunderstanding for sure. And there's a lot of diversity amongst Indigenous populations, but of course, in northern Saskatchewan, we're no different. So there's different languages and cultural practices and things. So it's hard to be able to really explain things in a way that makes sense within those languages. There's also limited cultural safety, and we talk about safety, but one of the bases of cultural safety is asking the patient, "Do you feel safe?" And we often don't do that, and we don't check in to see how that patient is feeling and what we could do to make things better for them as well. And then the other thing is there are often few interpreters when seeking medical care. And so sometimes what you see is that in some places, maybe getting a family member to translate, and that can be very difficult as well, and not necessarily lead to correct translations. or an assumption that somebody's a family member when in fact they're not. So confidentiality issues as well. We know that racism and bias exist for sure for Indigenous populations, and these are just two research studies that have been done on this, but there's been multiple studies and examples through the years, and that sadly continue today. There's, bias and judgment that happens, and people may feel that they're being treated in a biased way or a judgmental way as well. And sometimes it's more the systemic issues that are leading to some of these things for sure. Um, Many Indigenous patients will tell you that they feel that they're being judged or that they're being labeled, especially as things like non-compliant. We use terms like no-show, when in fact, maybe that person had multiple things that really were barriers for them to be able to even just get into the clinic. There are all kinds of systemic barriers. I mentioned that, for Northern Medical Services, we work across jurisdictions. So we work, for instance, on First Nations territories and in provincial jurisdictions and municipal jurisdictions. We work with four different tribal councils. There are actually three health authorities that we work with in Northern Saskatchewan. So we don't just have one. Um, and so it becomes very complex very quickly. And even as a clinician or a physician, it's difficult to navigate these. So you can imagine as patients how difficult it is to navigate. And sometimes when you're not feeling great, you just want what you want, and you get a bit frustrated with all these different pieces, and it becomes very challenging. And so one of the things I challenge people to do is instead of using terms like non-compliance or no-show, it really is a systemic inaccessibility that the patients are experiencing. So if we turn it around where it's not the patient, but the system, it helps us to start thinking a little differently about how we might change these systems to make it better and more improved for patient access. The other thing is that these things all have an impact on whether or not people are going to come to see you as a provider and whether or not they're going to seek further help from providers that may be further south and that are less familiar and, increasing the risk of some of these experiences that people have had. And all of these things delay care and lead to avoidance of getting health care or mistrust of the healthcare system. And these experiences of racism really shape whether people feel safe or not seeking care. And so, often these delays in care then are protective decisions. They're not about neglecting their health. So they're protecting themselves from these harms that they've experienced in the past. And what that leads to is then when you don't come in for the care, is that there's negative outcomes. And so when you do go in to see the, clinician, whoever they may be, there's often more judgment around like, well, why didn't you do this? Why didn't you get in to see us? And often then you're less healthy when you're being seen and diagnosed and treatment may be started, so less chance of success. And the access to diagnostics then is often reduced as well. And of course, this is a cycle that was described in Plain Sight, which was a report that was done by Mary Ellen Turpel-Lafond in BC, but applies to many different populations for sure across the north. We've also experienced things like wildfires, and we've had these for several years, but of course these are getting worse as time goes on. And again, this is another side effect of climate impact. We've had evacuations this year for wildfires, but we've also had them for flooding as well. So we're seeing kind of on the both ends of things. It does lead to interrupted care, and it does, people can have loss of medications. They might be dealing with new providers if these providers are even available for them. And, it just is very challenging when the entire community is evacuated. And this is happening sometimes even repeatedly over several months. And so that the idea of chronic disease management is then also disrupted. And that leads to problems with things like dialysis and medications and being able to follow up and being able to, feel well and being able to look after your own care kind of thing. Um, Chronic disease is sadly not uncommon in our communities, particularly things like diabetes, but we have all kinds of different things, coronary artery disease and COPD, infectious diseases, all kinds of things. So we often have patients with complex medical needs. We have increased rates of end-stage renal failure and happening as well, and thus a lot more need, I guess, for organ transplant as well. Um, Things happen very quickly. They happen at an earlier onset. And I have this within my family as well, where many of my cousins and my aunts and uncles develop very severe diabetes at a very early age. And by the time they're hitting their 30s, they're now in need of dialysis and such, sometimes even in their 20s. And we're seeing it kind of shifting earlier and earlier as time goes on. And there's less access for people around early care and prevention. And this creates increased demand for organ transplantations as well. And there still is a fair amount of lack of understanding around what organ transplant is about or who would have access to these things. And the other thing that I always point out is that we tend to focus on individual choices if people are making the choices to eat unhealthy and to not exercise and to not do the things that we would prescribe. However, access to being able to do these things is really often not the case for people. They might not have a choice on what they have to eat because they don't have the finances or there's nothing available in the local store if there's even a local store available. Often medications can be very expensive and out of reach for people. And being able to walk in the community can be challenging when there's no such thing as sidewalks. It's very bumpy and uneven. And like I said, feral dogs, wolf packs, like all kinds of things, bears we see right about this time of year. So lots of things to try to navigate for sure. So, what are some of the basics for transplants? Well, transplant care requires early diagnoses and it requires complex assessments and ongoing follow-up. And what that means is that there's a lot of travel back and forth to try to get these things done. And to be able to meet sort of all the qualifications and getting all the testing that's required in order to be considered for transplant. And so each of these steps are affected by geography, particularly when you're thinking about having to come back and forth and making sure that your kids have somebody to look after them, that you can leave the home for a time, what's going to happen when you're gone, all of these types of things. Some of the referral barriers include the late diagnosis. And again, when we think about people's discomfort in accessing care, that kind of makes sense. And the limited specialists, the geographic delays, all of those things. So patients that are living in northern communities are often referred later in the disease process for sure. And the root cause is due to access, not lack of engagement. And I just sort of posted this finding by Dr. Carolyn Tate around the fact that 50% of people in Saskatchewan are waiting for a kidney transplant are status First Nations. So it doesn't even include our Métis population. So again, disproportionately, we are seeing this in Indigenous populations for sure. So what are some of the workup barriers? Well, very similar things. Again, requires multiple specialist visits, often in urban centers, and each missed appointment can delay or derail eligibility. And it's not uncommon that if patients miss appointments, that over time the specialist may say, well, you can send them to somebody else because they've missed these appointments and we can't see them again. Even simple things like even if you are able to get your blood drawn, for instance, in the community, there are barriers on getting the blood samples out. So if the planes can't come in or if you can't transport the samples out, they're no good. If they freeze, like there's just a lot of challenges just even in getting blood tests done for sure. There are also waitlist barriers. Things like social determinants can certainly affect eligibility assessments. If you're Métis, you may not have the support to go down south to get some of these things done. And, social factors are penalized. If you don't have access to the resources, you don't have eligibility to the treatment. And there's also limited advocacy available for people as well. So factors like housing or transportation may be viewed as risks rather than structural barriers. And again, it may impact whether or not people can be seen as following through on the requirements to be on a wait list. Post-transplant barriers, Patients require ongoing monitoring, labs, medications, and visits. So again, this is this theme of having to leave home for travel, like traveling and leaving home and family repeatedly and having access to these things for sure. In terms of donation, there's often limited awareness around this and a lot of mistrust again of the system for sure. We have like lower rates of donation are often misunderstood. There is some thought in some of our communities around the idea that you have to be whole. However, there are others, and more elders, I would say, are talking about how this is a gift to a community member and to supporting one another. So we are seeing the shift in terms of traditional ways of approaching things. So it's not so much a lack of willingness for many people, it's a lack of access, culturally relevant information, and trust. Ethical considerations. So are we providing equal care? Is it equitable care? Our systems are built really for urban populations, particularly around organ transplant, and not much consideration around the rural and remote, particularly northern and high Indigenous populations, where there are these jurisdictional issues and all kinds of different things to navigate in order to get access to care. Throughout Canada, the geography is very similar, and the populations are primarily Indigenous populations with limited infrastructure. So these are commonalities we're seeing across the North for sure. So what are the strengths? Well, we do have strong community resilience, and they're not northern communities have amazing strengths, and they have strong kinship ties and land-based knowledge, and a strength of the culture itself that helps to give strength and impart that to the populations. And people have kind of a can-do attitude, I would say, and if given the opportunity, solutions can come from the communities themselves. And so there are many Indigenous-led programs that have been quite successful because once people have the understandings and the ability to have some say and be able to work on these things, they often are willing to come up with solutions and able to come up with solutions that sometimes we don't even think about for sure. So, some of the solutions I mentioned Indigenous-led programs. We've done a lot of work with telehealth and remote presence type of services and mobile services, more point of care testing, and continue to do that kind of work going forward, which has been quite successful in terms of being able to provide access to our communities, but also training community members to be able to work with these programs so that they themselves then have the capacity within the communities to deliver these different solutions. System changes, it's not patients who need to adapt, it's actually the system that needs to adapt. So finding pathways that are much more flexible and trying to figure out ways of transport that or travel when needed that is more appropriate and better supported. And trying to decentralize the care so that people are able to get more care at home where they are for sure. In terms of culturally safe care, having more trauma-informed care, language supports, relationship-based care are all critical aspects. And also checking in with patients, making sure that they are feeling safe and what can we do to improve that and to reduce those power differentials. Um, for donation opportunities, a lot of this rests with conversations that have to be grounded in relationships. So it means we need to spend time with people. We need to understand their understandings and thoughts and be able to provide clear education and around this. So that requires also that our elders are engaged and that there's trust building within this process. So key messages. I would say is that geography definitely has a huge intersection with inequality for sure. There are a lot of barriers across this continuum, and that a lot of these barriers are systemic in nature, not so much individualistic. And that we really, in order to be successful, need to have more culturally grounded solutions. And so, one of the things, again, I highlight is some of the work that was done, again, with Dr. Tate around a formation of a think tank that included patients and community members and traditional elders and people and providers alike to start talking together and figuring out what solutions were possible. So reflecting on like what assumptions exist and how can systems adapt. So I probably talked a little bit too much. I just wanted to say that equity requires different approaches, and thank you for listening. And if there are any questions, I'd be happy to attempt to answer them.
Thank you so much, Dr. McKinney, for sharing your insights and your experiences with us today. I know that I learned a lot about the realities of accessing healthcare for northern communities and Indigenous communities in Saskatchewan. I do invite everyone in the audience to pop any questions in the chat or to turn on their mic. We will be moving soon to our conclusion for day 2 of the CDTRP Patient, Family, and Donor Forum. But if we do have any questions, I'm sure they can be dropped into the chat quickly. All right, so seeing that, we don't have any questions at the moment. Again, I just want to thank you, Dr. McKinney, for your presentation. I think it's really challenged all of us to think more deeply about what equitable access truly means and how healthcare systems can better support patients and families closer to home and can start to address some of these systemic barriers. So on behalf of the CDTRP Patient, Family, and Donor Research Forum, thank you so much for your leadership and your advocacy and for sharing your knowledge with us today.
Thank you for having me. Take care, everybody.
I'd like to just quickly say something. Oh, she's gone. Oh, you're back. Hi, Dr. McKinney. That was an amazing talk you've just given. I am one of the PFD coordinators with CDTRP. And in my previous life, I was a nurse working in the Arctic, in Nunavut and in NWT. And that was last century. And what saddens me listening to what you're saying is in 40 years, nothing has changed. And it saddens me and it frustrates me. And I was there and was able to give good care. Based on the training I'd received, I was a midwife, I was delivering babies, so mums wouldn't have to go out for 6 weeks. But the sense I left with was the health system within the isolated communities and the different cultures. Like for me, it was Dene and Inuit. It would never fully function, it never functioned properly until the healthcare providers were from First Nations. Because, yeah, I can waltz in and give great care and try and learn as quickly as possible how to be culturally astute, to be kind and inoffensive in my approach to giving care. But if you can, if the healthcare workers are from First Nations, Indigenous communities, it's an innate sense that they bring to the job. And so I've been thrilled listening to the research that's going on, but also with the CDTRP, learning how many young people are going into healthcare from First Nations backgrounds. So my just 2 bits worth.
Thank you.
Yeah, and I just wanted to add Dr. McKinney as well. So I'm all about collaboration, and I see a lot of the things that we've discussed today go across cultures. So cultural safety and trauma informed. And I'm actually starting to realize myself that as I wait for my second transplant, that living further away from Toronto, I also feel I've been waiting 19 months, which is double the time I waited the first time, how much of an impact that has had, because I'm not going down to the hospital. I'm not seeing the team. And so not being there, and I'm fortunate that I'm not rural enough that I can't drive an hour to go get my test done instead of driving 3 hours to Toronto. But that is good. And I also like the idea of how, and this is the whole point of us doing these forums, is how CGTRP can all work together to help fix this system for all of us. So thank you to your work and to everyone's work. And thank you, Sharjana, for your great moderating and hosting. And we'll go over to Lindsay now to wrap up today's session. Thank you.
Thank you. Thanks, Sandra. So I just want to thank everybody that's, oh, there was one question. Marina Loth. I see a hand up.
Yes. So thank you for that, Dr. McKinney, for that wonderful presentation.
You're in my camp.
Is my mic on? Can you hear me?
Yep, we can hear you.
Anyways, I wanted to thank you, Dr. McKinney, for that wonderful presentation. That presentation, I'm also a member of Treaty 6. I live in Cold Lake, Alberta, and I'm a patient partner. I have CKD. Anyways, this presentation, like you speak about the rural northern areas, like I can resonate and relate. I think that it's to deal with, for me, I feel like it's because I'm from the reserve. Like I worked in the industry for 20 years and I moved home to Cold Lake in 2010 and I worked in the camp there at in the Synovus. And I worked with all foreigners and every one of them had a doctor. And I moved back to Cold Lake and I couldn't get a doctor or primary care. Anyways, long story short, had I got a doctor or had the doctor taken the time to say, I live between Cold Lake is 5 minutes away from the hospital and then Bonnyville. And I also had a doctor out at site. And no one told me I was marginalized and I felt that I was discriminated because I kept going to the hospital. And I knew I was sick and I knew nothing about kidney disease. And I was always sent home and I wasn't treated as such. And I think that I believe that had I been treated like a regular person or a newcomer, a new settler to Canada, I would have been diagnosed and then I wouldn't have had to have chronic kidney disease. And like you talk about like the environment and the travel, the lack of access. I go to Edmonton to see the nephrologist for 15 minutes and it takes me 3 days to go there on medical transfer and HIB. Like when are they ever at the table? Like it seemed like to me they're part of the problem. I can be on the phone for them for all day, on hold. And then where they put me, like I'm not culturally safe at some of those motels, those bed bug infested motels. I have CKD, so I'm on a special diet and it's not pizza and pop. And so there's no like it's take this or don't take nothing at all. And sometimes I get so discouraged. I don't even want to go. Like it's not worth the battle. I'm already feeling sick, but yet I still have to go to the doctor. But thank you so much for this work. And yeah.
Thank you for sharing that. I didn't even get into that because I know this is common. Just so people know, this is a common thing that people experience and they get tired of it and they feel like, I don't think I want to keep doing this. And like you said, being put in hotels or motels really more often than not. And then right next door to a McDonald's or a Tim Hortons, but you've got no money and no way to get anything else. Not a great situation. So thank you for sharing that. And I hope that things get better for you and that things hopefully get better is all I can say. But thank you for sharing that.